To make an effective contribution in optimising outcomes in patients undergoing major aortic surgery, anaesthetists need to have an excellent understanding of aortic pathology, have to understand the surgical options that are available, need to understand the perfusion techniques that can be used, be able to manage organ protection and manage the consequence when that organ protection has been insufficient, and have an excellent understanding of transfusion medicine, particularly the coagulopathy associated with prolonged cardiopulmonary bypass, the coagulopathy associated with often profound hypothermia, and the often resultant massive transfusion. It's also good to have an understanding of the 4 F's of aortic surgery. Clearly, the more familiar you are with the procedure, the more frequently you engage in aortic surgery, the greater and the patient outcome will be. There needs to be an understanding of all involved in the treatment team of the need for flexibility, that initial plans may change and intraoperatively innovative solutions sometimes need to be used to treat for unplanned outcomes. And certainly there's a benefit of forward planning. One of our clinical perfusionists did an audit of perfusionist attitudes to aortic arch surgery, and this is the result. The explanation is that often major aortic surgery occurs in a time-critical manner. It's often out of hours, it's often emergency. There are a number of cardiac surgeons and a number of perfusionists in any institution, and that the chance that those two have been done a case together in the previous 12 months is unlikely. So therefore, for the surgeon to say, "I will do what I did last time," is usually unhelpful. 2 a.m. in the morning isn't the time to come up with a new device or use a new technique that you've heard about in a recent conference. And so therefore you need a simple and reproducible technique to deal with this problem. And Bruno's a volatile Italian, and coffee is the solution to all things. I'm often still ridiculed when I bring the whiteboard into theatre when we're about to embark on a major aortic case, but it provides an ideal focus for planning for the case. Usually I get a member of the surgical team to draw the surgical pathology, and it provides an opportunity for nursing staff, medical staff and perfusion staff to all understand what the steps that are planned, and also to plan for contingencies if inadvertent outcomes occur. When things don't go right, there's the 5th F of aortic surgery. What informs the way I'm going to approach anaesthesia for aortic surgery is whether there is aneurysm or dissection pathology. Obviously with aneurysm I need to be aware of the possible mass effects of the aneurysm, and with dissection I need to be aware of the potential of malperfusion and organ ischemia. Whether the case is acute or chronic will usually be evident because it will be either an emergency case or elective. But importantly, I need to know the extent of the pathology, particularly if it's ascending pathology, know whether there's involvement of the arch, and if there's descending pathology, the extent, whether there's a potential interruption to spinal cord blood flow and involved viscera. If it's an acute case of the ascending, I need to know whether there's a presence of AI or tamponade that may alter my induction plans and may even necessitate peripheral cannulation for cardiopulmonary bypass under local. I need to also understand whether the coronary blood vessels are involved, understanding that it's the right that is normally dissected 10 times more frequently than the left. I need to understand whether it's a contained aortic pathology or whether there is leaking, and therefore having to deal with the situation of hypovolemia as well. And as we've talked about today, understanding the surgical plan, the bypass strategy, cannulation sites, planned cross-clamping options are all important. And then even just down to the simple practicalities of where I'm going to put my monitoring lines for arterial pressure and where I'm going to put venous infusion lines. It might be strange at the end of the day to be going back to aortic 101 and try not to be too simplistic. To operate on the aorta, you need an isolated segment of aorta to provide a bloodless field, either achieved by clamps or by circulatory arrest. Those clamps can either be external, or there's an ever-increasing number of complex endovascular devices. But importantly, organ ischemia can occur if an organ is if the nutrient flow to an organ arises from that isolated segment. If the organ is collateralized, then ischemia won't occur, but it's hard to define and to determine what degree of collateralization exists prior to surgery. Ischemia will be minimised if there is the presence of collaterals, if the amount of aorta isolated at any one time is limited, if the duration of that isolation is minimal, and if we adopt techniques that reduce the metabolic demand on that organ. Obviously, hypothermia is used extensively, either globally or locally, and in some circumstances, pharmacological agents may be of assistance. And if there is an alternative nutrient flow technique, such as antegrade cerebral perfusion, that will also reduce the incidence of ischemia. Protective strategies like CSF drainage in thoracoabdominal surgery are important, and has been touched on by other speakers. There's an ever-increasing amount of sophisticated end-organ monitoring to detect ischemia and therefore induce a change in strategy to reduce ischemia. It's probably worth mentioning, talking about malperfusion, because that's obviously a confusing aspect to aortic surgery. Initially, there's usually an entry tear that could result in the pressurisation of a false lumen that then can potentially occlude the true lumen. In most cases, there then is a re-entry site, and then we get pressure equilibration between the false and the true lumen. However, if we use this example, you can see if there's pressurisation of the false lumen, then you can get occlusion to tributaries, and that can either also occur if there is pressurisation actually compressing those tributaries. It is potential during aortic surgery, when we go from antegrade flow in the aorta to retrograde flow, to induce malperfusion intraoperatively. Therefore, we need to understand the implication of our cannulation techniques and where we have decided to site our cannulas. We need to have vigilant monitoring to detect malperfusion intraoperatively, particularly with bilateral upper limb, reliable arterial monitoring and lower body pressure monitoring. And any pressure trace abnormality, rather than the usual assumption that might be artefact, in a case of aortic dissection, any abnormality in aortic trace or arterial trace should be treated as malperfusion until proven otherwise. There are two key times when malperfusion can occur, and that is when the transition from pulsatile antegrade flow to non-pulsatile flow, retrograde in the aorta, and also the resumption of pump flow when the surgery is complete. Mass effect that can be caused by the aneurysm in the esophagus. It can cause problems with toe insertion and can cause pressure necrosis of the esophagus. It can distort anatomy, making line insertion difficult, and that's usually overcome by either the use of ultrasound or image intensifiers. Importantly, we need to ascertain whether there's adequate venous drainage of the neck if we're going to undertake antegrade cerebral perfusion, and it's of particular concern if you're in the left lateral position. And obviously there can be the compression of the left main bronchus, which may have implications with intubation. The actual act of inducing sleep in anaesthesia is either very individualised or quite institutionally different. The reliance on either volatile agents or intravenous agents, there's no solid evidence to suggest that one is either, and in fact probably most people use a combination of both. And if you go from different institutions, the actual choice and use of vasoactive drugs is remarkably different, but all with no real difference in outcome. We had the talk earlier about transesophageal echo. It's mandatory in these cases, particularly to be able to elucidate the aortic pathology, look at entry-re-entry sites, assess the aortic valve, to monitor true and false lumen flow and tributary flow. It's important to look for ischemia that may be manifest by left ventricular dysfunction, to monitor for distension, and to assess the post-bypass function. It has also been alluded to earlier to check cannula positions and monitor de-airing. Here is a case where we have 5 pressure transducers for 3 arterial pressures, pulmonary artery and central venous pressures. Looking more at neuromonitoring, we'll have a nasopharyngeal temperature to indicate cerebral temperature. We also have a bladder temperature to monitor core. BIS is used as a simple surrogate for an EEG, and certainly if there's a risk of interruption of cerebral blood flow, I will aim to have an isoelectric EEG by increasing the depth of anaesthesia. We have cerebral oximetry to monitor hemispheric levels of oxygen on the left and right, and importantly, when we undertake antegrade cerebral perfusion, we always monitor the JVP to be able to see that there is adequate venous drainage. There are more sophisticated tests that we don't have available regularly, either transcranial Doppler or evoked potentials, which require an additional neurophysiologist. To address the issue of organ protection, obviously the fundamental strategy is to reduce the exclusion time and to use hypothermia, which is globally protective. For cerebral protection, stringent blood control has been shown, blood glucose control has been shown to be a benefit, and obviously we can use antegrade cerebral perfusion, as George alluded to earlier. Cardiac protections via cardioplegia, spinal cord protections via the use of CSF drainage, and with viscera we can selectively cannulate tributaries and maintain nutrient flow. And the next part of my talk was to touch briefly on cerebral protection. Already it's been discussed the issue of hypothermia and deep hypothermic arrest and the advantages of antegrade cerebral perfusion over retrograde cerebral perfusion. There is some possible additional benefit by using pharmacological strategies such as steroids, barbiturates. I use barbiturates to achieve that isoelectric EEG if I'm concerned about cerebral blood flow. Mannitol and lignocaine are drugs that I use regularly. I can skip over this because George has already touched over it with similar information looking at the limitations of deep hypothermic circulatory arrest. So we can skip that at this time. And as you can see, we have come the full circle from deep hypothermic circulatory arrest to the disregard of retrograde cerebral to antegrade cerebral perfusion, the use of auxiliary cannulation, and now our technique of using branch first techniques and then antegrade selective cerebral perfusion. That's an anaesthetist drawing of our circuit for aortic surgery. We have a centrifugal pump as our main driving pump, and post the arterial filter we divide the line and run an additional circuit through a roller pump so we can control flow rates for our antegrade cerebral perfusion. Importantly, we have arterial pressures monitoring in both left and right arms, and we have line pressure monitoring for our cerebral circuit, and usually we never exceed 100 millimetres of mercury in that line pressure for the antegrade cerebral perfusion. A more elegant drawing is Bruno's drawing of the setup. For those who are perfusionists in the room, that might be of more use. When it comes to antegrade cerebral perfusion, the magic figure seems to be about 10 mils per kilo per minute, seems to give you regularly a radial pressure of our target of 50 to 60 millimetres of mercury. But that can be adjusted if there is need by looking at cerebral oxygenation and looking at cerebral oximetry or pressures. And certainly we aim to run our antegrade perfusion flows at as low a rate as it achieves us a satisfactory result. We run the distal body with similar blood pressures. That usually is a blood flow of 2 to 4 litres per minute. Because we're never going to we don't intend to induce complete circulatory arrest, our target temperatures will be 28 if we are going to maintain perfusion to the distal body, and 25 if we're going to have to interrupt distal perfusion to provide protection to the spinal cord. Interestingly, whilst there is little data to suggest or to document that cerebral protection via pharmacological agents is of benefit, in this survey 85% of anaesthetists responded that they regularly use neuroprotective agents. And as we talked about before, barbiturates, as I said, I use that to achieve an isoelectric EEG, not to be a specific neuroprotective agent. Steroids, pre-induction, mannitol regularly in our pump prime, insulin to maintain or to avoid hyperglycemia, and I use lignocaine regularly. The last area I was to talk on briefly was blood conservation in major aortic surgery. Importantly though, blood conservation is only one of the 3 pillars of patient blood management that has become a very important issue in the way we prepare patients for surgery. The reason it's also relevant is that for people in the room who are involved in the preoperative management of these patients, is there's a lot of data that suggests that if you have cardiovascular pathology, it's important to exclude and adequately treat anemia in these patients. Also, we have a preoperative screening process where all our elective cases are investigated preoperatively, and we have a process in conjunction with the haematologist for haemoglobin optimisation. There are combined guidelines from the American Society of Thoracic Surgeons and the American Society of Cardiovascular Anaesthesiologists about what should be done about blood transfusion and blood conservation in cardiac surgery. The risks are easily identifiable, and the strategies are, as we talked about earlier, increasing preoperative red cell mass, using drugs to reduce perioperative bleeding, surgical techniques to conserve blood and blood conservation such as cell salvage, to use blood transfusion algorithms with point-of-care testing has been shown to reduce blood requirements. But importantly, this is a multimodal approach that it requires cooperation between surgeons, anaesthetists, perfusionists and the cardiologists preparing these patients for surgery. The appropriate transfusion trigger for cardiac surgery is still unresolved, and we're actually starting the TRIC3 trial, which is specifically addressing that question about either a liberal or restrictive transfusion policy for cardiac surgery. So we'll have an answer for that in a few years' time. But certainly everything should be done to conserve the red cell mass. Of greatest import is the actual surgical technique to avoid red cell loss. There is some place for normovolemic hemodilution, and for major aortic surgery, cell salvage is routine. Hemodilution is a common factor in all cases requiring cardiopulmonary bypass, and it can be minimised by fluid restriction pre-bypass, the use of retrograde autologous priming and hemofiltration. There is a place for pharmacological agents, particularly antifibrinolytics. The other thing which is becoming more and more common is point-of-care testing and transfusion protocols, and here is a setup with a thromboelastogram and bedside and laboratory platelet function monitoring adjacent to an operating theatre. One of the newest areas in cardiac anaesthesia is a change in the way we approach managing haemostasis. There's a distinct trend away from the use of transfused proteins such as FFP and cryoprecipitate to the potential alternatives of using prothrombin, prothrombin X or fibrinogen concentrates. The use of fibrinogen concentrates is probably the most exciting thing that's occurred in the management of bypass coagulopathy. This is an early paper that showed that by using guided transfusion algorithms, particularly looking at the fibrinogen immediately post-bypass and targeting a much higher fibrinogen than we've normally thought. If you ask the haematologist or the blood bank, they'll say a fibrinogen of 1.5 is adequate. In this study, they're actually targeting a fibrinogen of 3. And they're able to show a dramatic reduction in drainage and the use of other blood products, with a reduction in the use of red blood cells, FFP and platelets. There now is a worldwide multi-centred trial that we tried to participate in, but there are no Australian centres, but this has been done in Europe and America. I just put this slide up to remind us of the complexities when it comes to the choice of blood products. Every state is different. In Victoria, we get provided our blood products free of charge, whereas to use fibrinogen, it costs me $800 a gram, and it's paid out of the pharmacy budget. So therefore, I can't access fibrinogen in my hospital. In contrast, in Queensland, where they've devolved the budget, a unit of cryo costs the hospital $200, so 10 units of cryo would cost $2,000, or 3 grams of fibrinogen would cost $2,400, and I think they actually get their fibrinogen cheaper. So they're actually able to choose a more effective product that has less side effects and is probably more efficacious because they actually have a devolved blood budget, and that's one of the difficulties we have in Victoria. That's my last slide, but for everyone who's involved in aortic surgery, it's certainly challenging, exciting, and I think there's something to learn out of every case we do.